Welcome to Stand By Us 2023, our annual event exploring the intersections of bi+ identity. However you identify, bisexual, pansexual, LGBTQIA+, or no label at all, we are delighted to have you join us.
We acknowledge the traditional custodians of the lands that you are all coming from today, and we wish to pay our respects to elders past and present, and welcome any First Nations people who are joining us.
Stand By Us is brought to you by a fabulous group of volunteers at bi+ Collective Australia. Come and visit our website, bicollectiveaustralia.com. Here you will find information about our program of events for this year, our code of ethics, and the ways that we can keep each other safe while attending. Please take a moment to have a look.
We're committed to bringing you up-to-date themes, topics and issues that concern people who are bi+ and our allies. If you're returning to us this year, welcome back. We're excited to connect with you again. And if you're attending for the first time, welcome, and please feel free to join as many events as you wish.
Wherever you're coming from today, welcome, and please enjoy our 3 full days of online and in-person events. These events all explore and celebrate the many vibrant ways bi+ people live, work, play, and connect.
From all of us, bi+ Collective Australia, happy Bi Visibility Day! And please, enjoy Stand By Us 2023.
Hello, my name is Misty Farquhar. I'm from bi+ Collective Australia and also from bi+ Community Perth. And today we're going to be talking about the future of bi+ health. It's a topic that's really important to our community because we do have poorer health outcomes than the gay and lesbian population, who have poorer health outcomes than mainstream society. So today we're joined by Meaghan Holden, my cute little partner, in discussion with national LGBTIQA+ health expert advisory group members, Carolyn Gillespie and Dr. Ruth McNair AM, as they explore the future of bi+ health in Australia. So they're all bi+ people themselves, and so they'll be talking about, from their own perspectives, bi+ health and wellbeing, research gaps, and their hopes for inclusion in the national 10-year action plan that has been promised to us by this new government. Meaghan Holden is the Director of Services for Switchboard Victoria and the Vice Chair of Living Proud in WA. Carolyn Gillespie is the Director of Services at Thorne Harbour Health and the Board Chair for LGBTIQ+ Health Australia. And Dr. Ruth McNair AM is a GP at Northside Clinic in Victoria and a researcher at the University of Melbourne. I hope you enjoy this discussion. I'll hand over to Meaghan.
My name's Meaghan Holden. I'm Director of Services at Switchboard Victoria, and I use she, they pronouns.
Hi everyone, my name's Carolyn Gillespie. I also use she, her pronouns, and my hats that I'm wearing, I have a couple. One, I'm the current Director of Services at Thorne Harbour Health in Victoria, which is the largest community-controlled LGBTIQ+ health service in Victoria and South Australia. And I also am the Chair of LGBTIQ+ Health Australia, which is the national peak organisation for LGBTIQ+ health and wellbeing, and those doing research, working to support community, providing services, programs and policy in that space. And I'm also a member of the current expert advisory group for the federal government into the development of the 10-year national plan.
Hello, I'm Ruth McNair, a GP, run my private practice in Melbourne in Victoria. I'm also an honorary associate professor at Melbourne Uni. I do a lot of research in LGBTIQA+ health, and I guess that's me. And my pronouns are she, her. Thanks.
Thank you so much. It's very lovely to be sitting in your company and having a chat. So to start off, can you tell us a bit about the LGBTIQA+ Health and Wellbeing 10-year National Action Plan Expert Advisory Group, which is the longest name I think I've ever heard. It just kind of rolls off the tongue. We'll refer to it as the advisory group. Can maybe Carolyn, can you start off? Just tell us a little bit about it.
Yeah, so the LGBTIQ plus 10-year national plan is really exciting and significant. We have never in the history of this country since colonisation or ever had a 10-year national plan that specifically looks at the health and wellbeing needs of our community. It's come about because of really years of tireless advocacy from lots and lots of people, including Nikki Barth, who heads up our organisation at LGBTIQ Plus Health Australia, but really other key people such as Ruth and other researchers who've really provided the evidence of the need. And we have a government that's really wanting to work in allyship and partnership with our community to create a plan that really addresses some of the immediate needs, but also some of the longer term chronic issues that our community faces.
Amazing, and it really is. It's a point in time and point in history for our community in Australia. Ruth, did you want to add anything to that or comment on?
Oh, just echo Carolyn's words. I think we've been wanting this to happen for a long time. It's fallen on deaf ears until quite recently. I mean, there have been advisory groups at several state and territory levels and produced some amazing action plans and strategic advice to government from LGBTIQA plus communities. So I think it's not starting from zero. Hopefully we can learn from those experiences and make something really useful.
Yeah, I think one of the things to say is there's such differing experiences for community where depending on what state or territory they live in and indeed in what part of states and territory they live in. I'm really fortunate here in Victoria. We have an LGBTIQ plus strategy here. We have a government that's incredibly supported to working with our communities, and there's an investment to specialist services such as family violence and alcohol and drug services so that we can actually create a service system that attends to the needs of our community here. But that's not the case everywhere. So for us to have some federal leadership and a national plan that sits to provide an overarching national position and strategy, it actually helps support some of those other states and territories that are less resourced or less further along the journey of inclusion for our community.
Yep, for sure. And also, political whims come and go, and Victoria will come out of this little hazy, beautiful time, and the strategy will be dropped. And so if there's something national that's an overarching plan that encourages this to be maintained, that's really helpful.
Yeah. I think also too, having a national strategy pushes those discussions in the states and territories where they may have other priorities happening, but a national initiative forces some discussion and input from each state and territory that maybe hasn't prioritised it as much, or maybe hasn't examined the data or information to inform their own policies.
Yeah, definitely. And I think what it does, it provides a lever to other national strategies. So, our health is not just because of the health system, it's because of those other psychosocial and, psychological, it's because of the other psychosocial things that happen to us. It's housing, it's access to employment, so it needs to be embedded in some of those other strategies and pieces of work as well. So it really enables a really holistic understanding of all of the ways in which our health and wellbeing is either promoted, all the ways in which discrimination and stigma actually, or the invisible nature of us in those other policies affects our community. So it's a really good stamp on making sure that there's some change.
Yeah, absolutely. So in shaping the national plan for LGBTIQA plus people, what excites you the most about the opportunity to advocate for the health and wellbeing of bi plus individuals, and noting that it's not just bi plus individuals, but there's a voice at the table and there's a lens. So what excites you the most about it? Ruth?
Yeah, I'm happy to start. Well, I think we've got a range of representatives around the table, and we also move out to our own communities and intersections as well. So I'm hoping that we can drill down to the subgroups in our community. Often when I've been involved with the Victorian strategic planning over many years. It's an overarching LGBTIQA plus strategy, and we do work hard to try and drill down to bisexuality, pan, intersex, and the other subgroups, because there is such a different range of activity and interest there in the community, and also such diverse range of inequities for these subgroups. So I really hope we can drill down a bit and get some key points for bisexual and pansexual people, as well as the other subgroups.
I think this is one of the biggest challenges it's going to face. The National Advisory Expert Advisory Group, or the EAG as they call us, it is a diverse representation of folks from across our community to really have a community-led plan in partnership with government. I think the challenges for us is we have such a dire situation for our trans and gender diverse community right now, that has to have a legitimate focus. But the important thing for me, sitting on that advisory committee as a BIPLUS person, is to make sure that BIPLUS issues are not forgotten in the importance of us actually attending to these other things. And I think despite us being the largest cohort amongst the LGBTIQ plus community, often the bi issues are an afterthought, or they're not recognised perhaps as being as significant or worthy of focus and attention. So I certainly will be there. I wore my little bi badge on my outfit when I was up in Parliament House the other month, and I think just being at the table is really important, and being embedded as part of the conversation, because when we support bi people, it actually benefits the whole of community, and I'm really excited about that. And the fact that there's a couple of us sitting on that committee, really having lived experience of what it is to be bi and to straddle all of the complexities of what that is and the joys of what that is. I think that's something that I'm really excited about.
That's fantastic. And that leads to, I guess, the next question. The research, Private Lives 3 research, but also others, shows that LGBTIQA plus people have poorer mental and general health outcomes than the general population, I guess. But it also shows that bi plus pan people have poorer outcomes than lesbian and gay identifying members of our community. So I guess there's two things there. Like, why is that? And I guess knowing that intersection of, say, trans and gender diverse and bi plus intersecting people, why isn't that discussion happening more when the data is there to show those poorer outcomes?
Traditionally it's been a very G and then L focused discussion. A lot of the research to date has looked at the whole of our community compared with heterosexual cisgender communities, and come up with those stats around disadvantage, which are very important. But then, we need these large data sets like Private Lives 3 to really understand the subgroups better. And so we are seeing this now much more clearly around bisexuality and pan, and also queer people, people of colour, etc., all of the intersections, that there's much worse mental health and physical health for some bi and pan people. And it's sort of hard to get that message out there when, as Carolyn says, the big picture issues are so important and so neglected as well. And why is it happening? We're still trying to unpack that in research terms, but we think it's partly about finding like-minded community, that it can be very difficult for bisexual and pansexual people to find their own tribe in Australian communities. So that's a big issue, and people feel very isolated and marginalised. Within LGBT community, the B is often quite invisible. It's there in the acronym, but often not there in reality in terms of policy or community services. So I think that's an issue as well.
And I think yes to all the things that Ruth has said, but I think it takes a long time feel okay around your own identity. So when you think about I'm bisexual, but that classic thing that we all do around, but am I queer enough? Like, where do I fit? I fit there, but maybe not really. And certainly for me, I'm in my 40s now, and growing up, you were lesbian or you were straight. So there was no language for my experience, and it took me ages to work out that I sat somewhere legitimately different to either of those places. And so I think the conceptualizing of even who we are, it's really only more in recent times that there is a real place for bi pride and for folks to feel like they can legitimately sit somewhere. You don't have to ultimately be heading somewhere else. You can sit around in the messiness of sitting in the middle, and that's okay. I just, as you were talking, I was also just thinking about, the impacts of misogyny. As a bi plus woman, you either get fetishized by heterosexual men or not delegitimized by other queer community, and that can be sort of the experience that you have. But for bisexual men or masc folk, the terrible biphobia that comes from everyone towards those folk make it so difficult. And you see a lot more bi women than you do bi plus men and masc folk, which I think tells us something about the homophobia and the biphobia that sits really deeply across our community still towards those folks. So I think there's a few factors that come together for that.
On the other hand, I mean, I see positives in the fact that more cis women are willing and able to identify as bisexual, because it means that our fluidity, which is there in everyone, but it's more possible to display that or to internally support it in your own identity and then to display that or express that publicly. So it's actually a more authentic way to be able to express your bisexuality if that's where you sit on the spectrum. Yeah.
And the relief for your mental health when you can affirm who you are. And I think we can't underestimate that. Living in secrecy or shame has catastrophic impacts for people's mental health. So finding a tribe and finding a spaces where you can feel okay and feel legitimized is really incredibly crucial. And, going back to the plan, I think having some of these bi issues and experiences written into that process just really helps support bringing us visibly with the rest of our community.
And the other thing that you raised, Meaghan, was that intersection with gender identity and the fact, particularly for pansexual people, it's very intimately connected with who they're attracted to, who they have sex with, how they feel about their own bodies. And so the intersection between pansexuality and gender identity, or being a diverse gender identity, is really strong. And that's another thing that's hard to unpack, because we spend a lot of time in mainstream health professional education explaining that there's a difference between sexual orientation and gender identity and bodies and sex characteristics. So, we're down to that very 101 level of explanation, when actually we need the next level up of saying all of this intersects in the one person. We cannot disaggregate one's sexual identity from one's gender identity. These things combine in the one person really importantly. And often that comes out in people who are pan, because they're saying, well, my gender identity is also quite fluid. And that needs to be understood both in the LGBTIQ community and also in the healthcare sector. It's a hard message.
Yeah, it is. I mean, I think just picking up on some of your points, Carolyn, similar for me, it wasn't until in my 40s that I identified as bi, because, for me growing up, it was pick a team, you're straight or you're gay. And I said, okay, well, I'm lesbian then. And, it wasn't until I guess being older, language was changing, that I was able to be in a space to reconsider that. And I think that, we've come a long way, and certainly I think young people currently are incredible and very open about questioning or exploring or using terminology. And I just, I sit in admiration, and it gives me hope. But generally, I also think we've still got a long way to go. You know, we're still very binary in our thinking as a society. You're male or you're female, you're gay or you're straight. Those conversations are still very much there outside of certainly my little bubble of people that I talk to. And, you know, I'm able to have these great exploratory conversations and be in spaces where people understand it. But you step outside of that and realise that there's still a lot of conversations that need to be had in mainstream to understand the beauty and breadth of gender and sexuality, and that it's all okay too. You hear people say, "Oh, it's just trendy to be bisexual now." Really? Is it? Because young people are more open and more owning of their gender and of their sexuality, and
it's the same conversation around, oh, all of this stuff's making more trans folk. And it's like, no. Trans folk have always been there. You just haven't seen them, and it's been too dangerous for people to affirm themselves. So actually, this is just representative of a closer representative of the actual reality of the diversity in our community.
Yeah, absolutely. Yeah, I guess as there's more visibility, you do sometimes see a bit more pushback, and certainly I think we're seeing that now. And also just picking up on community, that how difficult it can be for many people who are bi or are bi but are in relationships with people of a different gender, to own their sexuality openly. And I hear this story from many people that they may be living, I don't like the term straight passing, but this is a term that some people do use. How do they own their sexuality when it's not necessarily recognised in their day-to-day life because of the gender of their partner? And it's so hard, and to find community is just so important for them to be able to be themselves, because they don't necessarily get to walk in the world owning their sexuality every other day.
There's a lot of policing of identities in community, unfortunately, and that's partly about keeping a safe space for everyone, but actually that marginalises people. I mean, I had an example recently. I just helped run the Lesbian Medical Association conference, and that was a great event. We had 90 people there from all around Australia and New Zealand. And I mean, case in point around the name, it's actually Alma now. We do include non-binary people and bi people, thank God. But, we had a sort of U-Butte dinner, we dressed up in 1920s gear. It was amazing. But a couple of people brought their male partners or their trans male partners. And I just got this sense that they were sitting in the corner, they were sort of feeling like they weren't quite as accepted or acceptable, even though we were trying to create this hugely inclusive environment. But, there were a few looks, I think, and it was just, we've got a long way to go to be sure that we are creating a safe space for everyone in our community.
I was talking to one of my very close bi plus colleagues the other day, and we were talking about exactly this, that if you're bi plus, so if you're a bi plus woman like me, and you have a female partner, there's a legitimacy around your bisexuality in that space. And so I could take my female partner in this example to Pride Mart and kiss her without any question whatsoever. But what would it be like if I brought my heterosexual male partner to that experience, and would I feel as accepted? And I know that there would be this justification of feeling like I'd have to demonstrate my queerness because my partner doesn't outwardly then represent my internal bisexuality. So it's really complex, I think, for how we feel included, and our internalized own biphobia around that stuff is something that we have to reckon with constantly.
I mean,
Yeah,
it's also
absolutely.
a big issue for older people. Let's say they've been in their heterosexual relationship for decades, their partner dies or they separate, and they sort of come out as bi, and enter into this community, it's quite hard for them as well to say that legitimately they've been this all along. They just, had a lifestyle that was different for a time. I think that's something our community needs to work with, the variety that we have in our
I think less policing in general. Let's just make that.
Yes, let's make that a rule. Yeah.
Yeah, make that a rule. Yeah.
And I think that's a really important point, because it isn't just, mainstream society. It isn't just government policy. It's our own community as well. We've all got work to do in, understanding, in less policing, in just more acceptance of the diversity and fluidity of identity. Yeah. So, what specific health needs and challenges faced by BI+ people would you like to see featured in the action plan?
Well, I've got one to start with. I think from Private Lives 3, we've drilled down to a few of the sub issues like mental health, alcohol and drug use, family violence. And the thing that keeps coming up is access to health services, especially primary care, general practice, maybe community health. And we see repeatedly that if a person has a good GP or someone they trust in the health system and has come out to that person, then they're more likely to have access to other parts of the health system. They feel more comfortable and safe to then talk about issues such as family violence and access appropriate and inclusive services. So, and unfortunately, in the Private Lives data we've analysed, it looks like the bi and pan women particularly are less likely to have a regular GP. Can't work out why. We need more data and understanding around this, but even less likely than the lesbian and gay people in that study to have a regular GP. And so that's a concern, because they're less likely to have therefore access to parts of the health system that they should and could be accessing.
And I think that's especially so, Ruth, isn't it, for bisexual folks who are in heterosexual normative relationships where GPs or other primary care touchpoints are not even thinking about LGBTIQness, because the presentation, they're making a whole bunch of assumptions about who's walking in.
Exactly.
So I think when it's missed at the beginning, then it starts a whole cascade of invisible experiences the whole way along. So there's missed opportunities for engagement around what's going on for people. As you were talking, I was just thinking about data, and as I've gotten older, I've become a bit of a data nerd. I'm embarrassed to probably say that. So I think one of the things that I want to see come out of the 10-year plan is for the questions to be embedded in all of the places that we have touch points. So we know that heaps of the time, like, I barely ever get asked about my bisexual status ever. Like, it's just not a question and I'm always surprised when I'm asked, because most places that you have contact with are not really asking, and if they do, they ask badly or they don't really know what to do with that information. So there's a whole competency and skill piece. I think, tragically, we were refused to be put in as questions in the last census. So we have these big, important, all of population pieces of data collection where to date we haven't existed, or they haven't extrapolated out that information. So I think hopefully one of the things that will come out of this plan is a really strong commitment to getting some really good, cohesive and consistent collection of data about the existence of bi+ people, and then from there you can actually extrapolate further out what the needs might be and create a system to respond. And this is a sort of longitudinal piece of work, but I think there's some excellent practice happening in some places. So how do we harness that and actually make sure that whether a bi+ person is connected to the LGBTIQ+ community or not, the whole of their selves is actually attended to in whatever way they're seeking support.
Yeah, I think that we know in the LGBTIQA+ community, we talk about coming out isn't an event. It's something that happens over and over and over. But I think that, Ruth, going to your point around GPs, because of the presentation for many bi-plus identifying, pan identifying people, the onus is put on them to come out because there is an automatic assumption. You know, you've got kids, and I have this as well because I have 2 kids. If I mention my kids first, I always get surprised that people say, you know, will say your partner, he, or, you know, what does your husband do, or something like that. And it's like, seriously, like, what part of this says I have a husband? You know, but because I've said kids, they've gone, oh, well, you must be heterosexual, you know. So I think for bi-plus people, especially in a health setting, if that assumption is made, they have to mentally think about, do I have the strength today to come out and maybe explain my situation, or to feel like I have to justify my life?
There's still a huge fear of discrimination in the health sector. I mean, that's why, I'm sure that's partly why a lot of the bi and pan people in private lives weren't accessing regular GPs, because they feel this fear of being discriminated against if they do come out. They just might shop around and, you know, go different places for different things. You know, I know lots of people have their sexual health needs met in one place and their mental health needs met in another place. And that is really not ideal health service provision. You know, collecting all of one person into one place, your sexual health and mental health are intimately connected, etc. You know, having a good primary care approach or primary healthcare approach is the way to go. So, you know, I think there's a lot of education to be done in the healthcare sector around reducing this level of stigma and the idea that bisexuality is somehow negative. You know, we need to be training up the new healthcare providers to say this is just part of human existence. You need to be encouraging disclosure, but also making sure your environment is safe to disclose. You know, I know lots of people who disclose specifically to one person in a healthcare setting, but tell them, do not tell anyone else in this place because I don't trust anyone else. That's also extremely difficult for everyone. So there's a lot of work to be done around destigmatizing bisexuality and making sure it's just a normal part of questioning.
And I think that's particularly so, Ruth, isn't it, for folks who are trans or gender diverse, where the complexities of what's written on your Medicare card might be your dead name and then your preferred name, and the way of living doesn't align with the bureaucracy of accessing care. And then you add a bisexual experience and identity on top of that, and you're already trying to flap around dealing with all of this bureaucracy of stuff, and now it's something else that takes energy to have to advocate, and you have to be somewhere in your own experience where you're actually in that position and you can be bothered doing it at that point in time. So I think it is multifaceted. And
the other thing obviously is that if a person is presenting as trans or presenting with issues related to being trans or non-binary, that can take precedence, you know, so that's the number one issue that keeps getting trotted out, even though they might be coming in with totally different things. And it's quite common amongst the trans non-binary people that I see that they really haven't been asked about their sexuality at all or their sexual health. And that's, I mean, sexual health, you know, how do they create a healthy sexual life? So, you know, that's a huge gap. That's a missing piece because it's not hard to ask about sexual health for anyone, whether they're trans or not.
No, and from there you get to safe relationships and other risks around mental health and physical safety and those sorts of things. So the whole pathway is lost if those early parts of that conversation don't happen.
That's right.
That holistic view of a person.
So which is still quite radical, bizarrely. So
yeah. So talking about research, you know, and we know that, you know, I've been in meetings in this last week with Professor Ashley Lim, who's been talking about the different data, and I know Ashley's part of the advisory group as well, is, you know, looking at the different research that's already happened to help inform this action plan, and it informs policy more broadly, and, you know, is really, really important. The other part of that is where there's gaps in research, you know, we're not informing policy and direction and identifying needs. So in your opinion, what areas of research related to BI+ health do you think should be prioritised in the action plan to ensure the policies are inclusive?
Yeah, look, I'm happy to start with that. I think we have a lot of gaps still around bisexuality. I mean, we now know a lot of details, such as poor mental health, more alcohol and drug use, higher STIs, and all those very pathologizing pieces of data. But we don't still really know why it's so different amongst this group. And so if we're prioritizing research as one of the outputs of the action plan, it will be trying to drill down into those issues. You know, what is different about the health of bi people? Why is there such disadvantage? And therefore, what should we do about it? I think there's a huge opportunity to hear from the community. There's going to be a range of consultations over the next few weeks and months, which are designed to hear from a diverse range of our community. So I think I'd just encourage bi and pan people to attend those consultations, because they'll be both online and in person. But, you know, have your voice there in the consultation, because I don't think there's a specific one to bisexuality. If that's, did you notice one, Carol?
No, yeah, no, they're all of the rainbow.
Yeah, so, you know, we'll again need to be having our voices heard in those consultations, because drawing from community understandings and need around the country, rural, regional and urban, in different settings, will be really important, given the lack of data that we have. At least hearing from people here and now about what they feel the needs are will be filling a gap. So,
yeah, I think there's definitely a need for greater disaggregation of data. And by that I mean the splitting up of the letters. And a good example of that is last week the Australian Bureau of Statistics released the new round of personal safety survey data, which is a national population data set for people's experiences of different kinds of violence and stalking and street harassment and sexual violence and whatnot. For the very first time in that survey, they ask questions about sexuality. So there is a data set that tells us that LGB plus people, and women in particular in this survey, experience 2 to 4 times higher rates of violence than their heterosexual counterparts, which we know this, but these statistics are still always really shocking. But what it doesn't, so that's a great thing that that's embedded in there. Of course, it didn't ask about gender, so we didn't get any trans experience in that, because I think surveys and things still struggle with asking all of the questions that are needed to understand someone's experience. But I think while that data is really great, what it still doesn't do is split up. It still lumps everybody into one experience. And I think this is our continual challenge at the end. You know, urban experience is different to regional experience, which is different to the experience of a newly arrived, forcibly displaced person who's got a whole different story, or someone of First Nations background and lived experience. So I think, you know, to try and split out by issues from those things is still really important in how we ask questions, which is why the private lives study is such an important one, because it actually does some of that for us.
and actually we did some analysis of the longitudinal women's health study a few years ago now, but that was a really important outcome. You know, we looked at bi versus lesbian women, and what was the strongest predictor of the worst mental health for the bi women was intimate partner violence.
Yeah.
And so, you know, those two things were so connected, and we could tease that out in that study because we had enough people to look at. So, you know, there is a big piece around violence, violence being directed to bi and pan people, even more than lesbian and gay people. And how does that then impact the rest of their health?
And what does it mean if our family violence service touch points are not asking about that experience,
I mean,
to understand someone's risk and you know, their what you might do to support them.
And again, you know, that's an example of when people are having those experiences, the onus is on them to come out. And you need to weigh up, like, am I in a position to do that? And quite often people just aren't. They're seeking supports. They don't want to have to, come out about their sexuality. That is not where they're at the moment. But those assumptions are made and those questions aren't asked.
And someone may not even know themselves the links between their bisexual identity and some of those other things that we know from research and from broader conversations every day with the communities that we work with. So I think, there is, as Ruth said, I think the takeaway is that there's still a lot of gaps, and we really need to make sure that part of the messaging around the national plan is the importance to really do nuanced collections of data and information so that we can design responses that are specific to the diverse needs of our community and for bi plus and pan people in particular.
Yep.
Yeah.
If there isn't a line in that plan that says every national data set has to include the full set of questions around LGBTIQA plus, I'm going to be horrified.
We'll be writing it in pen
on
all of the copies.
Red pen. The colour of your cup, Meaghan. Red pen. The colour of my jumper. Because that's not a hard ask. It's not going to add financial strain to the survey. There's going to be 3 extra questions or 4 extra questions. But I mean, aside from that, also we can collect the data, but we also have to make sure the analysis is detailed, because sometimes we collect data and it sits in the drawer, it's there, but nobody's analysed it in detail. And that's the other part of that, to analyse it and then bring it back to policy when we find the differences.
Which is the really important point about researchers and policymakers and, having representation from our community leading that research and that understanding as well, so that the analysis is correct and legitimate and accountable back to community. I think that's really important too.
Yeah, absolutely. Ruth, you were mentioning before about consultations for the community, and we absolutely would encourage people to participate in that and to I guess lend their voices to the plan where they can. Do you know if is there going to be opportunity for submissions as well for the different bi groups around the country that might want to contribute?
I don't know the answer to that, actually. Do you know, Carolyn?
I don't know if that's the case. I imagine there will be. There's definitely a formal consultation process like there is with the development of any national plan. But I think certainly there are everyone in the room from our community are fierce advocates for making sure that the consultation process is comprehensive, and we don't want to develop a plan that doesn't have legitimacy to our community because they don't feel like they have had the opportunity. So I think there is an absolute shared commitment between government and all of the advisory group members to make sure that happens. Yeah,
it's interesting you were saying like there's data, there's not enough data. I guess there is data there, and it does show poorer mental and physical outcomes for bi plus people. Although there's not enough, there's still a lot that tells us there are, disproportionate outcomes. So in knowing that, why don't you think that there are, specific dedicated bi plus programs established when the bi plus community are, a large population, the largest in the acronym? Why don't you think that there's dedicated supports?
I think it comes down to money and funding streams. So, we've seen for many years that the funding stream that we have to tap for LGBTIQA plus health generally is sexual health, HIV/AIDS. That's where the money has been, or suicide prevention, which is so important. So, that comes through to the community as a whole, or about the community as a whole. And groups like Thorne Harbour and ACON and others have to very creatively use that funding for other parts of the program. So I just see that it's really hard to focus in on subgroups such as by women or, whoever the subgroups are, people with disabilities, when the funding streams are so global or general to our community.
And I think coupled with this is we know that our community is the largest part of the LGBTIQ plus cohorts, but I think there's a real lack of recognition about how many bi-plus folk exist in the world. So that, the ongoing impacts of biphobia, stigma, discrimination that prevent people actually talking about their whole selves and who they are means that there's an under recognition of the need and an under recognition, so people don't feel like they deserve to have a specialist service, or even that one might be possible, but also that the other side is that service systems don't see a need because we're not capturing data, we're not asking the question. So it kind of is this double invisibility, I think, that sits there that contributes. And very pragmatically, when governments and funders make decisions about what gets funded, if you're not in the data, you don't exist. And so, that pragmatic need for, which is why I've become a data nerd as I've gotten older, because it is the lever to compel change. And that's why, the personal safety survey that I mentioned before, the fact that it now records LBQ women's experience in that, even though it's not capturing the wider experience of our community with trans and gender diverse experience yet. For the first time, we have some shocking and compelling evidence that enables folks like Ruth and I to go to government and go, this is absolutely unacceptable. There has to be something different done here. And all of the people who are activists and allies and contributors to change can utilise that data to really move things on the dial for better to make it better for bi-plus people.
And I mean, it comes back to your point, Meaghan. Do we need bi-specific health services? I don't know the answer to that yet. I think we need to ask bi and pan communities about that, because clearly the mainstream services haven't been very inclusive. And also there's a lot of critique around the LGBTIQ specific services as well, and the fact that bisexuality can be quite hidden or not overtly included anyway. So I think, people fall through the gaps in both systems. So there'd be an argument for having bi-specific services. On the other hand, my holistic brain is saying, well, surely health service that covers everyone should cover bi people well as well. And I mean, we have to think,
as you said before, bring the whole of yourself, whether it's your trans experience, your bi experience, your migrant experience, to one provider who can actually take care of all of you.
So that's the ideal. And I think if you have to have bi-specific services, they end up being a niche. They might end up being a niche service that is hard to have sustainable funding. So, we've got to look at the whole health service and how that can be much more appropriate.
I think, in terms of the data, and it's showing that, the bi-plus population is the larger part of our community. But as you were saying before, Carolyn, quite often the questions aren't asked, so that we can assume then that there's a massive underreporting of both identity and issues for bi-plus and pan people. We're not asking the questions in the health sector, or not even just the health sector, across a number of domains. We're not drilling to that level, so people aren't reporting. So we're not counted, even though the data shows a higher proportion. You would have to assume it's a massive underreporting, which is so concerning.
Hence the need for a national plan. Yeah.
So you wear your data nerd hat proudly.
I'm comfortable with all my identities, Meaghan. Data nerd being one of them.
I hear you. This is where we connect here. So on a final note, if you could wave a magic wand and achieve anything for the bi-plus community in the plan, what would it be?
Oh, that's such a big question.
I can make it bigger. It could be, achieve anything. What would you love to see for the bi-plus community?
For me, it's legitimate visibility of our lived experience. I think that, for the young folk coming through, and I sound 4,003 years old when I say that, but for young people coming through, they're not having the experience that I did, where I had no language for who I was until I was in my 30s, really, and, sort of bounced around in different spaces. I want young folk to go, oh, here's a legitimate language to describe my lived experience, and for that to be supported and celebrated, and that's just part and parcel of the questions and things that are asked in accessing healthcare, and those links are made between that experience, the other intersections that people live with, and tailoring then a response that's safe and helpful for people. I think that's what I would love to see come out of this.
Yeah, I want what she wants.
And a bi takeover of the whole world, to be honest, yeah.
Or is that already
Prime Minister?
Yeah.
Is that already happening? Because there is a reporting. Maybe it's happening.
Yeah, that's right. Yes, a bisexual Prime Minister. Yes,
Yes.
I love that one, Ruth.
Yes,
Yeah.
That's the bi agenda, isn't it?
It is totally. That's why all of the our enemies are so jealous and reactive towards us, because of the power of the world it will create.
Yeah, it's so powerful.
Let's face it, we are everywhere. Yeah.
Yeah, we're everywhere. Yeah.
Yeah.
Thank you so much. It's been such a pleasure to talk to both of you today, as it always is. But also, I just want to say, thank you for your representation, both at the advisory group, but in the work that I know both of you do every day. It's so important, and I think it's important for the BI+ community to know that these discussions are happening, that there are both folks sitting at the table and are here to support, and certainly we'll be putting out things about the advisory group and submissions, perhaps consultations for people to have their voice heard. So thank you so much.